role of imaging in ASD, how it alters the decision making and outcome. So some illustrative case scenarios I will be discussing with a special reference to transthoracic and transesophageal echocardiogram. So the role of imaging in ASD, as all we know, is helps us in accurate anatomical assessment in different views. We understand the margins and size of the ASD. We get a idea about degree of pulmonary hypertension, how much is the level of shunt, that is the overall assessment, the right ventricular and left ventricular function. If there any additional defect like associated pulmonary stenosis, or there is any anatomical variation like bands, which is not very uncommon in case of ASD in small kids. ASD imaging has an enormous role during the transcatheter management, where the difficult ASDs are require help of transesophageal echocardiogram. I'll show some cases where the balloon occlusion study and balloon sizing, which help to know the ASD better and treat that, and post-operatively definitely it will be of use. So the first case is an ASD in a younger boy. So this first case one I am showing, this is in the subcostal view. We can appreciate an aneurysmal inferior margin, and there are two holes. The superior one is the big hole and inferior one is a small hole. So two issues in this small child is aneurysmal ASD and two holes with a bigger hole superiorly. So this is a frozen image of the same. The superior hole measured approximately 22 millimeter, the smaller one 8 to 10 millimeter, and total length. So this actually, the ASD runs from this inferior margin to that margin. It's frequently difficult to exactly decide on the size of the ASD based on the floppy margin, because we will be banking more on the solid margin. So we took the child in the cath lab, and in cath lab a detailed transesophageal echocardiogram done to delineate. So this is in the 90-degree axis view. This is RA, this is LA, and this is the superior vena cava superior margin, and we can appreciate this is the larger superior hole, this is the smaller inferior hole, and there is a significant amount of tissue, but it is floppy type. So we decided, because it is a floppy tissue, which will allow us to put a big device in the superior hole, and thereby we'll be able to push the septum more inferiorly, and it will be possible to close the defect. So here the most important part was crossing the ASD through the upper ASD, and that required T guidance. So you can appreciate we have this catheter, and that catheter was crossing the superior hole, and that fact has been confirmed only on transesophageal echocardiogram, and that is the key point in the closure. So here we took a 28 millimeter atrial septal occluder in the right upper pulmonary vein approach with wire support. So another wire and catheter is kept in the left upper pulmonary vein, and under TE guidance we close the defect. So this is post procedure a stable device. You can appreciate all the margins caught well, and in the inferior there was small residual which was not considered very significant, and that same thing came down in 6-month follow-up. So this illustrative case is an proof for utility of detailed transesophageal echocardiogram or additional imaging in case of difficult ASDs. The second patient is a 54-year-old gentleman with a class 2 effort intolerance, exertional palpitation, and he detected to have a large atrial septal defect. So, has increased pulmonary blood flow in X-ray with ECG showing right axis RBBB pattern. So, again, a transthoracic echo, the measurement as we commonly see in the 4-chamber view or in short axis was not coming more. It was around 28 to 30 millimeter only. But in adults, we always embark and we do a pre-procedure transesophageal to know what we are dealing. In the subcostal view, we were seeing a deficient superior margin and inferior margin was floppy. This is the subcostal view, this is LA, this is RA, this is the part of the IVC and this is the inferior margin we are seeing. My arrow is there. That was little floppy. And here in the frozen image, I have just tried to get, it's a big ASD, but there is a small dip of the color. And that color was the hope color, because it was telling we have some margin. So in transesophageal echocardiogram, the maximum dimension we got 38 millimeter with floppy inferior ring. You can appreciate this is nearly 90 degree with little modification, superiorly, inferiorly, and this is that inferior floppy margin. In the frozen image, we can appreciate the same. This is in the 0 degree view rather. So the options were cardiac catheterization, knowing the coronaries and surgical intervention, bar, CAG and device closure. The patient opted for, after detailed counseling about the procedure, both cardiac surgery and cath discussed. Patient opted for transcatheter remedy. So we informed the surgeons, they are kind enough and kept the OT free for us, because there was a risk that if we are taking the device may embolize. So the good part, the PA pressure was normal in this gentleman with a mean of 13, and left ventricular end diastolic pressure, which can be high in that age group, was not elevated. The coronary artery was also normal. So all these are the 3 checklists for any patient in the adult. When we are trying to close a large hole, we should ensure we are fine in this category. So equalizer balloon used and then balloon assisted device closure was planned. Now here we had a 38 millimeter hole, so we had to request and specially order a tailor-made 46 millimeter LifeTech atrial septal occluder. Here again, transesophageal echocardiogram was key, because we wish to have this balloon in position. Unless we confirm the position of the balloon in the right place, we cannot deploy the device. So this is a 46 millimeter custom made ASD device from LifeTech, balloon assisted and nicely sitting or getting deployed. And this post release, you can see the bulky 46 millimeter device completely occluded, no residual flow, was discharged on aspirin and clopidogrel. Now it is not 2-year, rather 3-year post procedure. He is doing extremely well, and the device, which was so bulky, in the 6-month time came down in a very normal profile, and the heart reorganized itself. So again, the transesophageal echo came in big way in helping us treating that patient. This is an interesting patient where again I'll discuss how the transesophageal and detailed evaluation helped us to come to a decision. 46-year-old lady, known case of ASD with a saturation 98%, significant effort intolerance, and admitted with respiratory symptom. Now, one interesting part of that X-ray I wish to highlight is significant dilatation of the MPA. And overall, the periphery, the vascularity was not that increased as I expect it to be, though cardiothoracic ratio increased 2.67, which may be part of dilatation of the RA. So ECG showing sinus rhythm with right axis RVV pattern. Now this ASD was again a big ASD, 36 millimeter with bidirectional shunt. There was mild pulmonary stenosis, but the TRZ was not very good. So the grade of the pulmonary hypertension, I was not sure because there was some bidirectionality involved, RV dilated with dysfunctional and IVC congestion. So all these things were not looking very good that this hole is divisible or closable. We wanted to interrogate the same in cardiac catheterization. So RA mean pressure was 16, PA pressure systolic 60 with a mean of 30, and aortic pressure mean of 90. When we calculated this QPQS, it was coming 1.5. So the pulmonary blood flow was not very significantly elevated. The PVRI calculated was not high because the PA diastolic pressure was low, but overall PVRI SVRI ratio in the presence of less shunt was not very looking good. We decided to test occlude the ASD with a 33 millimeter equalizer balloon, and here again the TE was helping to know whether we have stopped the flow across. The LVEDP, which was 30, jumped to 40 and patient developed symptoms. So you can appreciate the very high LVEDP in that patient. So that was telling the patient will not tolerate that closure and we should not embark on closing the defect. So in view of severe left ventricular diastolic dysfunction, intolerance to balloon occlusion, we decided not to close the ASD and keep her on medical follow-up, and TE guided balloon occlusion and hemodynamic assessment helped in this decision making. The next patient, this is a very interesting patient I am now trying to share. A 27-year-old lady who was referred for device closure of a 25 millimeter secondum ASD. The RA and RV we can appreciate was dilated. So the RA-RV was significantly dilated. Regarding presence of ASD secondum, there was no doubt. But when I was doing the subcostal image, the size of the ASD was not coming very big. If we see the two dots are between 10 millimeter, this was around 10 millimeter or 12 millimeter maximum. So this secondum ASD, which I felt is not more than 10 millimeter or 12 millimeter in size, was unable to explain the degree of right ventricular dilatation, and that was the catch. So I decided to do transesophageal echocardiogram and I got surprised. And what was the surprise? 0 degree, I am showing very high, and we can appreciate there is an additional ASD, and this is basically sinus venosus ASD. I'll just come again. This is in the 0 degree, this is in the 90 degree, and here we can appreciate in the 35 degree, one red flow is coming. This red flow is the flow of right upper pulmonary vein. So we are dealing with a case, in addition to the secondum ASD, we have sinus venosus ASD. So what was happening in this particular case? Now in 125 degree, I could open both the defect. You can appreciate this is the RSVC, this is the septum, this is the aorta, this is the regular, I'll just regular ASD, what we were seeing is around 10, 12, 15 millimeter, but there is a huge sinus venosus ASD above, and these two in combination was the reason for RV dilatation. And once we have found an additional large secondum ASD ostium sinus venosus ASD, the case no longer is favorable for any transcatheter regular intervention, though nowadays we are trying a little bit. So it was sent for surgery. So again, when I came back and tried to see where I missed, and because I knew by the time that there is an additional hole, so on very careful interrogation I could observe is sinus venosus ASD. So I myself did that ASD interrogation initially, but this was very difficult to get. TE helped to reach to the diagnosis, and finally this you can appreciate in three-dimensional TE. This is superior, this is inferior. We are seeing from the RA side, this is the secondum septum, secondum ASD, and this is the sinus venosus ASD. So this interrogation helped completely change the directive of the treatment. And the last aged series patient I wish to share is a 49-year-old lady, functional class 2, ASD, pulmonary hypertension. She was diagnosed and she was suggested surgery, but she had faith in one of my colleague, Dr. Dilip. Her Gurudev told that to go to Medica in our hospital to get treatment. This is something little bit of divine. So how divine things help. Again, in X-ray is cardiomegaly, PA dilatation with increased flow. We can see the end-on vessels. So in transesophageal echo, transthoracic echo, we got 30 millimeter ASD with moderate pH. We can see RVSP 40 plus RA. RARB significantly dilated. In the subcostal view, we can appreciate this is the IVC, this is the SBC, and it is a huge hole. And here I was not very sure that the IVC rim is very good. It was looking little more risky that whether we should attempt, because here I was not being able to get a nice inferior rim. In the transesophageal echocardiogram, I could appreciate there is a small nubbin of tissue in posteriorly. This is in 0-degree view. This is RA, this is LA, and this is a posteriorly small nubbin tissue. In the 90-degree, I could appreciate there is a floppy margin, very thin IVC rim. The HD was mainly left to right. So 3D and 2D in combination, finally 36 millimeter ASD with floppy and deficient posterior-inferior rim. So this was again a very challenging case in an adult lady with mildly elevated pulmonary pressure. So on cath we found the pulmonary pressure rather more than echo, 68-28 with a mean of 44. LVEDP was 28 to 30. So I just wish to compare the last patient, what I showed with this patient, that similar type of pressure, but here one thing changed, and what changed is the QPQS. QPQS was 3 here, unlike the last patient, which was 1.5. So here, this was the reason we decided to attempt that case for device closure. The PVRI was 3.7, CAG was normal right system. So in view of elevated LVEDP, planned for fenestrated ASD device closure of 40 millimeter amplage. So you can appreciate this is the device, and 5 millimeter around fenestration created inside that ASD by cutting the fabric and expanding that region. So we deployed under balloon assistance here and stable device. We can appreciate some flow in the next. I think the good part of the story, the PA pressure, which was 68, post-procedure came down to 40, and LVEDP also from 28. Usually we don't take the high LVEDP, but reduction of the LVEDP and PA pressure with patient remaining stable, we decided to release the device. So stable device, pre-discharge, you can appreciate the PA pressure here coming 25 plus RA. And this is that fenestration's flow. You can appreciate small fenestration, but it was not shunting very well. The purpose was to immediately bail out in case of any difficulty. We did not or had not any trouble in the post-operative, and 6-month follow-up, she was doing excellent. And so this is the pre-discharge image of that lady. discharged on aspirin and clopidogrel. So, in conclusion, I wish to tell imaging in ASD, transthoracic is less invasive, adequate in good windows, particularly in small kids. But in the adult, we need TE, which help us with more detailed evaluation. It is required for large and difficult ASD like multiple ASD, deficient and floppy margin, ASD with band, balloon occlusion and assistance. TE and transthoracic both basically complement each other in the difficult gray zone type cases. And in adults, mandatorily, we do a preoperative transesophageal echo to have a preferable outcome. So I'm happy to end the session. The first talk, sir, Dr. Singh is listening. Please let me know. Let me know. I tried to share all these interesting cases.
That is absolutely good because those were kind of all varied classes or types of ASD procedure you've shown, from easy to difficult ones. So if there is any question, we can have it on the chat box. So, doctor, do you have a second part of this, or?
Yes. I have some case series, interesting cases I have kept. So okay. As long it go, I can start that next presentation, where a very interesting case I'll show. So I have such interesting case series as kept, and you just let me tell. So I'll start then next. You are okay with that?
I think we don't have any questions right now. So
we have a couple of questions.
We can continue with. Okay. So there are just two which I can see actually. Ranjit, there are more questions there, but this shows that in the patient with raised LVEDP that you did not proceed with, we would have put a fenestrated device and waited for 1 hour and then decide.
So it's a very good question, I must tell. Two things which were not very favorable we felt. First, the overall QPQS was not very high. It was 1.5. ASD had bidirectionality, and C had additional respiratory issues. So closing and hole, long-term benefit possibly we were not giving. Nowadays, a different substrate is coming, where in pulmonary hypertension, we wish to create a hole. So it is the atrial flow regulator type of devices are in place. So we wish not to close the ASD where there little bit of doubt. A 54-year-old lady with a elevated PA pressure, elevated LVEDP, which is going up, we don't know how she will behave after the discharge and etc. So we decided more respecting the natural history of that case.
I think that's a perfect approach. There is a question that how do you select size of the device? So in which situation would you consider fenestration? Again, I think asking for the same thing. In which situation would you consider fenestrated device?
There are two indications basically for fenestration. The first indication is when we are having moderate level of pulmonary hypertension, where we feel that it can go up in future. So we are fenestrating the device as a pop-off for future elevation of the pulmonary pressure. And nowadays companies are coming up with a tailor-made fenestrated devices which can be available on demand. LifeTech does have such fenestrated device. Also, Occlutech company has already on board. So this is the indication one. The second indication is raised LVEDP. So if LVEDP is, we feel that it can go up or it is not very good, we can put an tailor-made fenestration or a fenestrated device which will be of use. we need to put a significantly big device so that we can put a, if we are making an fenestration.
Yeah.
3D echo is just to understand
Yeah,
the
3D
live.
echo.
2D echo is more essential in especially transesophageal.
And then the use of pulmonary vasodilators for future device closure. The question is, balloon tested case, would you like to follow up with pulmonary vasodilators for future device closure?
We can give pulmonary vasodilator and we can follow up, but the patients who have significant elevation of pulmonary artery pressure, we usually do not embark on closing the holes. Where we have idea that this overall shunt is good and by closure he will get benefit. So under pulmonary vasodilatation, those moderate grade of pulmonary hypertension we can try, but with consideration, discussion with the patient that he will be on long-term dual pulmonary vasodilator and on follow-up that he should be very strict to. So the cases are not very simple that we just hook a device and come off and the pressure can go up in future.
Okay. And the question is, sinus venosus ASD are a specific indication. These are being closed by covered stents. We have now done 3D of these in London. And that's a separate topic. This is Professor
I think it's
Qureshi is responding.
I think it's my pleasure to be to Professor Shakil Qureshi, who is chief of Evelina Clinic London, to be in this talk. He is the pioneer. He has published the stenting closure of sinus venosus ASD as a transcatheter approach in CAT-CVI. Yes, sir. What you tell?
Can I unmute Dr.
Sure, it will be my pleasure. Please unmute to Professor Shakil Qureshi.
Yeah, can Dr. Shakir, do you wish to respond? You can have your video on and audio on.
It will be great to have Shakil Qureshi's input.
Yeah.
Can you hear me?
Yes,
we can.
Shak, it's so good to see you in the seminar.
I'm trying to unmute the video, but it won't. It says the host.
Yeah, host has to. Indresh, could you manage that?
We are doing it, sir.
All right.
Starting.
Yeah, so Anil, this is really interesting session. I thought I would join in because of the timing being correct. Sinus venosus ASDs, now we've done 30 of these, and they're a particular way of doing them, assessing them, using covered stents. And so that's going to be a new evolving technique around the world.
It's so good. So that's what I was just having a passing comment. So when I did at that time, it was just in making, and now you have made it as a looking like in future course of intervention in cardiology, where selected cases will undergo this covered stent closure. The paper is very good. Love to read and enjoy it. And thank you for sharing. It is so nice on your part, Shaq, to forward the paper. And Dr. Siva was very willing to have that paper because to get an input that how best it can be done. Thank you again.
Can you please remain on video and this thing, and we would love to have more interaction with you.
Yeah. Okay.
Yeah. We go ahead with the questions, and your inputs are also welcome, sir. So now we have a mild PAH. What is your approach?
Mild PAH usually is up to 45 millimeter of systolic pressure. Usually we make it a part of significant shunt, so we don't bother and we just close the ASD and they do very well. It's the moderate to severe pulmonary hypertension that is only of our concern, and especially after closure or balloon occlusion, or in fact after closing the ASD by divisive pressure goes up. Those are the substrates which haunt us, and to be a little more careful before releasing the device.
Yeah, now the question is 65 years old male with mild symptoms with a large 3 centimeter ostium secundum ASD. Do you use TEE every case or only in select cases of infants and children? And the second is, how do you select device size with adequate and inadequate rims?
I think very interesting. In adult, as a policy, all the patients do and get a transesophageal echo prior to coming to cath lab. And if they are very straightforward with adequate margin, we close under transthoracic in the cath lab, but pre-release we check transesophageal. That is the first component. But any patient having deficient margins or floppy margin or double HD type, they mandatorily get the whole procedure under transesophageal echocardiogram. So this substrate adult, yes, TE has a big role. In pediatric patient, if margins are good, we see very well, and usually we do only under transthoracic. Transesophageal is, as I showed in this case, which is very restrictive to multiple ASD or extremely floppy, where we want to be sure that we are adequately closing the flow. So selective cases only TE, otherwise transthoracic only in small kids.
So I think people want to know what are the current guidelines for closure of PFO by a device.
PFO
Indications of PFO device closure.
PFO device closure, now the detailed guideline has come from different academic bodies, and it is recurrent cryptogenic stroke. When we are not getting any other indication, and that is the most common indication to close. Apart from that, I think platysmia orthodoxia, and some cases of migraine, but that is still in the doubt. Like both ways, whether migraine is going to benefit or not. And Dr. Shakil is there; he can tell. I think he is master in again. Shak, if you can tell.
So in the UK, until a few months ago, about 6 months ago, we were different from rest of Europe and USA and rest of the world in that our view was that there was not enough data from trials of managing or closing PFO devices in patients with recurrent strokes. Now there is sufficient data to indicate PFO closure in patients with recurrent strokes. So that is becoming or has become an accepted line of treatment, although funding is still an issue in the UK. And then the other indications that you mentioned, platysmia orthodoxia, and migraine, certainly not. Our NHS will not fund PFO closure for migraines. And then diving very occasionally to prevent bends.
Thank you, Shak, again for giving your input.
So question from Dr. Subhash is, do you find difference in 2D echo right heart pressures and pressures by cardiac catheterization?
By and large, if very nice tricuspid regurgitation we are getting, and the other features, secondary features, they usually parallel. Very rarely we get surprise, and that is mainly in the cases where we did not have a very good jet to help us to get correct pressure. By and large, it will be parallel. Like transthoracic will give us a good input about transcatheter pressure.
Yeah, but I think recently a lot of info is there that the correlation between cath pressure and TR jet velocity is at the best 0.6, not better than that. And reasons being that if you have a severe TR, the compliance of RA actually comes into play. And the most variable thing is the RA pressure, what you calculate by IVC. That's where the deficiency. And anyway, I think we can get a pretty reasonable this thing from. So next question is that Kindly comment on current role of 3D in ASD device closure.
I think 3D is very interesting, especially in adult transesophageal, mainly to understand the location, and if multiple ASDs are there, they are very, very useful in closing, because you separately see two holes. I showed one such example where sinus venosus and another hole. If we have two holes, secondum ASDs to know, and after closure also. So 3D mainly helps, and nowadays a new technique has been developed where Philips machine is integrated in landmark with that Philips CAT machine, where the 2D 3D combination will be helpful with the navigation. So those things are very limited in a few of the cath labs as of now in India. I think outside it is there, and that will have a role. So mainly additional AHDs.
So I don't see any more questions. Any comments from Dr. Shakir?
One of the questions I've just spotted is, I don't know why I can see them. What is your experience with cardiac erosions after device closure? So the comment there is that device closure is very, very rare. And the majority of device erosions have been reported really with the Amplatz ASD device. There are a few patients that have had device related erosion with Occlutech ASD device, and very small numbers of the other devices. But the problem with that is that there's not enough rigid follow-up data available for us. There was another question which was about RESPECT trial and PFO. Well, in the UK now, we've started accepting PFO closure in stroke patients. I think those are the main comments. And the 3D in adults, absolutely essential, really. Not in straightforward single ASDs, but especially when there are multiple ASDs and you're trying to work out whether to close all of them with one device or multiple devices.
The questions have cropped in. When do we not close an ASD on intervention, I mean, excluding pulmonary artery hypertension?
That one illustrative case I showed, in that particular lady, the left ventricular diastolic pressure rose to 40s. So this is another indication, in addition to PAH, that if significant diastolic dysfunction in an elderly, we don't wish to touch that particular ASD. Medical follow-up is better.
And what do we, what antiplatelets we use, and for how long? What are the guidelines?
Usually, single antiplatelet aspirin, 3 to 5 milligram per kg for 6 months will suffice, except in a very large ASD, say 36 and above. The institutional protocol to give dual antiplatelet for up to 1 year. One exception for very adult with AF, that substrate will require anticoagulation. So aspirin plus warfarin will be a right choice for that group for prevention of future complications.
So there's a question for fenestrated ASD, what is your approach? And that's what, I mean, the question ends there. For fenestrated ASD, what is your approach?
Regarding the anticoagulant,
I don't know. I mean, the question is...
I think my interpretation is that they want to know how to deal with and close fenestrated ASD. That's quite a long question, really, or the answer would be very long. That is, you have to make a decision about how far apart the fenestrations are and whether you think finding a central hole would close the other holes with one device. Otherwise, you'd have to plan for 2 devices. So that's quite a long question, I'm afraid.
Now, the question is, Are there any specific set of patients amenable to interventional closure of sinus venosus ASD, and those with less override of IAS, and are they better suited?
I think Professor Qureshi is the master who has streamlined this new entity closer, so he can answer that specific thing from his own.
Our experience has been that about 75% of sinus venosus ASDs, firstly in the UK, when we started this and up to now, we've focused purely on adults. We haven't gone down to teenagers or children. It's possible that a fully grown teenager would be amenable for this procedure. And then on the anatomy side, most of the sinus venosus ASDs are suitable for this procedure with the covered stent. The exceptions are when there is a large right upper pulmonary vein which drains high up in the SVC somewhere near the azygos vein. And there, obviously, we cannot dilate that by a catheter method. That would leave a significant anomalous drainage into the SVC. And if we feel that, and we talk to our surgeons and they say that they would be able to divert that vein to the left atrium, then that patient is usually referred for surgery. And then the only other situation is where we do interrogation with the balloon, and if the anomalous pulmonary venous drainage is being compressed, either fully obstructed or severely compressed by a balloon, then the stent that we are going to implant may well compromise that pulmonary vein, in which case we also do not proceed.
I think the question comes up again, how do you select device size with adequate and inadequate rims?
Adequate rim 2 to 4 millimeter in pediatric, not more than 2, and in adult 2 to 4 depending on the location, should be okay. In an inadequate, it depends on the whether there is a floppy margin or more thick margin. In floppy margin, it will require even more, and there is no one single magic number for any particular ASD. The floppy things require bigger one, and it may require an balloon assessment, particularly significantly aneurysmal ASD, require experience of the operator to decide. Usually 6 to 8 millimeter in adult, it can go up regarding the size of the ASD, but this is not a straight jacketed answer for an inadequate margin. Adequate margin, yes, 2 to 4 millimeter more than the size of the ASD.
The question comes, what hardware you use to fenestrate ASD device?
So it's tricky. It requires a very sharp type of surgical scissors. So from OT we get these very sharp scissors and try expand this region where we want to make a hole and approximately cut the fabric in that location and try to dilate it through a 14 French dilator or 13 French dilator to make that hole reasonably well. Though this, in long run, this kind of fenestration do not last long. So they gives us only temporary benefit. So the tailor-made ASD fenestrated devices, they are possibly the answer for more durable type of communication creation.
We tend to, rather than make our own, in the past we used to, but they tend to close over a 3 to 6 month period. So Oxitec, if we tell them what size device and what size fenestration we want, they manufacture it for us.
And that's great, Zach. That, you know, I think getting a tailor-made device is the best.
So I request people to kindly ask the question. We have authorities there. I mean, can't be a better opportunity than this. So if there is no more question, maybe
I can show the next interesting. This is a visual delight type case. A good good T demonstration of an interesting case. I hope people will like it.
We have all the time, sir.
Okay, sure. Thank you. I'll just go again, share my screen. It will be. So now, this is a short, interesting echocardiographic case, just to again stress the importance of detailed imaging, especially transesophageal echocardiogram, in deciding the fate of a patient. So, a 36-year-old lady, a known rheumatic heart disease, had severe mitral stenosis with a mitral valve area of 0.9 square centimeter, moderate mitral regurgitation, mild aortic regurgitation, moderate pulmonary hypertension, and good function. So that was the basic diagnosis for which she underwent surgery in 2016. The mitral valve was excised and a bileaflet mechanical mitral prosthesis was implanted with a 20 ethibond interrupted sutures. She had an uneventful recovery and discharged on day 7. Post-discharge echocardiogram showed a normal excursion of the disc. The pressure gradient across the valve was 3 millimeter H mercury, trivial MS, and she was fine for a post-operative evaluation of a mitral valve replacement. 6 months after the surgery, the patient presented with 10 days history of significant breathing difficulty with mild exhaustion. They clinically had features of heart failure. So it was very surprising she was getting, and she had no history of fever at that time. So in apical 4-chamber view, we were observing good device movement. The valve was in place. LALB was dilated. There was good mitral inflow, and there was some regurgitation, which was little ectopic in nature. So mitral regurgitation was there, and which we considered was the cause, but this mitral regurgitation possibly paravalvular failed. The mean mitral gradient we can appreciate it's 21 is because of a significant mitral leak. In the parasternal view, we can see a significant mitral leak. The disc was moving well. So there was associated TR and significant pH. We can appreciate the right ventricular systolic pressure 73 plus RA. So we were dealing with a significant mitral leak associated with pH. There was systemic venous congestion. We can appreciate the full IVC. So we were not able to understand the true nature of the leak. It came to me for possible closure of paravalvular leak. So I wish to interrogate the lesion in transesophageal echocardiogram. So in transesophageal echocardiogram, the tricuspid regurgitation jet, again it's high, signifying PS. We can appreciate a hugely dilated LA. And that was again considered significant. So significant MR which was coming from the lateral annulus region. So I was seeing, you can appreciate here, the leak is coming from the lateral annulus, which was significant. The jet exactly was difficult to get. Usually in the paravalvular leak, we get in orthogonal plane jet exactly coming from some place, and we can know the size of the leak. But here it was getting very difficult. In X plane, I was started seeing the leak, which was from the lateral annulus. Here we can appreciate there was a significant amount of gap between the lateral annulus and the valve. So mitral regurgitation through the lateral annulus region. We can appreciate now better the same place. This is the lateral annulus, this is the valve, and we can appreciate the leak. The 3D clinched the diagnosis, and the whole purpose of showing this case, this was more than paravalvular leak, rather the whole 50% of the valve dehisced from the lateral annulus. So you can appreciate the whole semilunar shape, the whole region has come off, and you can appreciate in the frozen image, this whole lateral 50% of the valve is no longer attached to the mitral annulus, and it was extremely rare. I was expecting a leak of say 6-10 millimeters something, and whether we can hook a device there, but it was more. It was a almost dehisced valve. So the decision was, you can appreciate from below. This is the from inferiorly we are seeing the valve, and again this is that whole part giving away. This is in the 3D, colored 3D. We can appreciate the whole semilunar leak. So the valve 50% dehisced. So the patient was sent for surgery from the table, and that was the game changer of a detailed evaluation by transesophageal, especially 3-dimensional echo. Even 2-dimensional was not giving that perspective. It is very difficult for the surgeons to accept the patient from the OPD to the surgery unless they are convinced that this is a dire emergency. So he underwent surgery. They found similar type of result what we communicated. The same mitral prosthesis was reused and secured. He was discharged on day 8. Post-discharge again, and good story, 4 millimeter mean gradient and no pH and good function. And this is the post-discharge, the pre-discharge echocardiogram showing good valve movement, no leak. And this is a 6-month follow-up. She's doing extremely well. So the idea, detailed history, clinical evaluation is essential to get correct diagnosis. Transesophageal echocardiogram is very, very helpful in diagnosis of adult valve lesion. 3D echo adds value to the diagnosis significantly and is useful in communicating the lesion to the surgical team. Surprise during detailed evaluation is not uncommon. All it needs is an alert clinician. And thank you. I just wish to share this and Dr. Singh this case just to give an input regarding how imaging is helping in a particular case, convincing my surgeons, and the augmented role from 2D transthoracic to 2D transesophageal to 3D transesophageal.
In paravalvular leaks, Anil, we do catheter closure both transeptally and transapically retrograde arterial, but we do not do any of them without 3D transesophageal echo assessment. And what your message is absolutely essential, that it has to be you've shown fantastic images, and there's no argument about dehiscence here. Sometimes you see a patient in the clinic and transthoracic echo shows paravalvular leak. By the time you get them into the hospital and into the catheter lab and do transesophageal echo assessment, planning to close the leak may have actually become bigger.
Yes.
And so, we don't puncture the arterial vein or anything until the 3D TOE has been done immediately prior to the procedure.
Thank you, sir. Thank you.
Absolutely good, sir. Very good case and very good presentation. And I think we still have questions regarding the previous case. Let me go back to okay. So we go back to the question that what do we do with a stretched PFO versus an ASD?
The indication is stretched PFO is not an indication. If the lesion is hemodynamically significant, then only it merits closure. For the closure purpose, the PFO closure indications are different and ASD indications are different. If there is a recurrent cryptogenic stroke with a very small ASD, possibly that wall also will require closure. If it is very proven that ASD, there is some shunt happening.
So some wants to know that what would we do in case we've done a PFE device closure and you still see positive bubbles on Valsalva or otherwise?
So in that sort of patient, you have to be able to differentiate between flow or leak through the device itself, and additionally, very occasionally, you may have patients who have micro, so pulmonary AV malformations. Those are important differentiating features to sort out. So you'd have to take the patient to the catheter lab and reassess whether there is a leak through the device, and that will have to be transesophageal. If there isn't, then you have to focus on the pulmonary side, pulmonary AV malformations.
Correct.
Thank you, sir, for the attention.
Yeah, thank you, sir. Dr. Momin wants to share one case and wants to know what you do, ask the experts for that. 18-year-old female with the ASD and severe PS causing a bidirectional shunt. So how would you approach this?
Very interesting entity. If there is a significant pulmonary stenosis, especially valvular in nature, we should address that fast. We should try to open up the pulmonary valve. If pulmonary valve has been well taken care by balloon dilatation and pressure came down, the next stage we should close the ASD. First, it should be pulmonary valve.
Yeah, I agree, because we don't see that sort of scenario in the West, but in developing countries, Asia, Africa, that sort of clinical scenario is encountered. And so it would be too brave to do the valve and the ASD in one sitting, because the right ventricle may take a while to readjust. And so it'd be better to deal with the valve, wait for a few months, and then go for the ASD.
Okay, and again the question for stressed PFO versus ASD velocity criteria. Which rim is not important for the device?
Majority of the cases, maybe 40 to 45% have a deficient aortic margin. So aortic margin deficiency is common, is not considered contraindication or difficulty, except decision of the which size of the device will take. Inferior posterior margin, that's the most critical. If it is absent or bald, usually we don't target at all. If it is floppy and small, yes, with operator expertise, with assistance, it can be taken. Superior margin we don't consider as a hindrance in closing the ASD. Shaq?
Yeah, I think I agree with that. The aortic rim is really, we don't worry about at all. And the IVC rim, if it's absent, that should be considered a contraindication.
So, they wanted to know that what was the reason for dehiscence in that patient?
In retrospect, surgeons, whether interrupted sutures is hypothetical. After 6 months without an history suggestive of infective endocarditis, it was a surprise. That was in my case, the 3D was essential to tell them, look, it is not a leak, it is dehisced. Exact reason is a guess. We anticipate whether interrupted suture, some of the sutures gave away, and once, as Dr. Shakil was telling, one leak, and when it starts, it begets leak. So slowly, in short span of time, the valve has given away.
Perfect. And we can request our members to either, there are two options, send your emails on the chat box, your names, mobile number, so that, we kind of formulate a database and becomes far easy for us to, get to you for future webinars or repeat webinars or retelecast. And that there's a sent a link as well where you can directly click the link and go to a WhatsApp group where we just pass on information about webinars only. So now let me go back and ask the questions again. What is the approach of infants who have a mild to moderate ASD? How it's followed up? What is the indication of closure and what age?
Usually we don't touch before 3 years of age. Only 5% of the ASD is less than a year may have symptom attributed to ASD, and only small fragment of the patient will be recommended if it was considered that the ASD is the reason of the growth failure. Otherwise, we don't touch. So it will be less than 5%. That too significantly symptomatic.
So in the context of the patient who underwent device closure with 46 mm device, any role of measuring total septal length when considering use of a large ASD devices?
Not really.
Can future remodeling after device closure lead to erosion later?
So far I have done 4 cases of 46 millimeter in Kolkata. Septal total length used to get measured earlier, nowadays no. The right atrium is so dilated, or atrium is so much dilated, and the device is soft. Usually it accommodate and reframe to the heart shape. It is never a issue in the long-term follow-up. I have 3 years data of all the patients are on active follow-up, and the devices, to my surprise, was difficult to understand that it is the same device which I put. So they usually remodel nicely.
Dr. Momin wants to comment about the same patient, I presume. He said it was done in 2 sittings. The patient with the ASD and the PS with the bidirectional shunt. Patient doing well, but RV diastolic dysfunction is progressive. The PPG across pulmonary valve is 25 only.
So whether some diastolic RV dysfunction is in place, that may be the reason. In long-term pulmonary stenosis, there may be some RV thickening and dysfunction. I presume that should be the case. Dr. Shakil, I think you can.
Yeah, I think that's the reason why if you did both the procedures in one sitting and there were problems, you're going to know the underlying reason behind the problem. And this highlights that, I think it's important to do it in 2 sittings. There is a right ventricular problem, and we could have made it worse by dealing with it in 1 sitting.
So over to Ranjit, Indresh. I think we had an excellent case presentation, fabulous, and we have authorities on this and that made this conference and this webinar a big.
I must thank from core of my heart to Team Philips and Dr. Singh, and my surprise is to get Professor Shakil Qureshi, whom I know for last 14 years. Is a teacher like to all of us, and getting him for the webinar is a surprise, and an authority joining and speaking. That's what I started in the beginning, that it will be a learning session for me, and addition of the input from Professor Qureshi was really good addition to this whole webinar. Thank you, Sak, again for being with us.
Perfect. That's what they say. The best things come by surprise, and they're free.
I wanted to surprise Anil because he does a lot of brilliant work on educational front anyway, and also the timing. This sort of timing was better for me than seminars which are earlier in the morning for you when we're asleep, and of course the lockdown has helped a lot as well.